Here is your question. Right. So if you have read and understood, considering the history demonstration, kindly begin. Dr. Tole, kindly begin. Kindly begin. It's recording. Sorry, I got disconnected. Kindly begin.
Okay, ma'am. Good evening, sir. I'm one of the executives. I'm Dr. Mpora. May I confirm your age and name, please?
I'm Mr. Smith, 54-year-old.
Thank you. How do I help you? How do I help you today?
Okay, I'm here today because I have problems with my breathing. I have pain with breathing.
Sorry about that.
Oh. All right.
So where exactly is the site of this pain? Can you tell me where exactly are you feeling it? You could touch it.
Okay, it's on my left side of my chest.
Okay, that's okay. How long ago did the pain start?
About 6 weeks now.
Okay, that's not all. Did the pain start suddenly or it's been gradual since that time?
No, it's gradual.
Okay,
Then
how would you
started
describe
increasing.
it? Okay, it's
Yeah,
been
the
improving.
pain. Yes, the pain is just dull. It's dull on that left side.
Okay, that's noted. How would you, okay, you said it's dull. Since you
Yes.
noticed it, the pain gone elsewhere since you noticed it?
No.
Is there anything you do that makes the pain worse?
Yes, initially when the pain started, when I want to do activity, maybe my jogging or start to do something fast, the pain becomes more severe. And even now, even when I'm not even doing anything, the pain is still even now more severe.
So sorry about that. Sorry about that. Is there anything you do that makes the pain go or relieves you of the pain?
Nothing. Except analgesics. At times we make the pain to go a little bit and then it will come back again.
Is there a particular time of the day that you notice that the pain comes? Or
No.
does it have a period that it comes?
No time variation.
It's okay. On a scale of 1 to 10, can you grade this pain?
The pain is 7, no, it's severe, so I'll grade it 7.
Sorry, sir. Are you having the pain now?
Yes, a little.
Are you comfortable with me continuing with the history, please?
Yes, you can go ahead. I will enjoy it. Go ahead.
Okay, sorry about your pain. I understand that you may be uncomfortable. Thank you so much.
Yeah, thank you, doctor.
Okay, is there any difficulty with your breathing?
Occasionally, just slight difficulty.
Is there any cough?
No, no cough.
Okay, have you noticed any unintentional weight loss over the past 6 weeks?
No, I don't have weight loss.
How's been your appetite, sir?
Yeah, my appetite is fine.
Okay, that's noted. Are you on any treatment for any medical condition by your GP?
Yes, I have a problem with my breathing. Well, the doctor said it's COPD. So he's giving me some medications, and then I had pulmonary embolism about 4 months ago. So I've been on warfarin therapy now that the doctor said I should be using.
So sorry about that, sir. And how regular have you been on that on those medications?
Yeah, I've been using them as prescribed.
Okay, fine. Have you had any surgery in the past?
No surgery in the past.
Is there anybody in your family that has a similar complaint or a similar condition that you are going through, sir?
No.
Okay, may I ask some other questions? What do you do for a living?
Yeah, I'm a businessman.
Do you smoke?
Yes, I smoked for about 15 years, but I've stopped since about a year ago now.
How many sticks were you smoking per day when you were smoking actively?
Yeah, averagely 3 to 5 sticks per day.
3 to 5 sticks per day?
Yes.
Okay, that's noted. Do you drink alcohol too?
No.
Okay, that's noted. Do you have any idea what could be causing your symptom presently?
I don't know, doctor. I don't know.
Okay, that's noted. Do you have any concerns aside from the fact that you have a COPD and you are on warfarin? Do you have any other concerns that you may want?
Yes, my concern is I hope it's not that the pulmonary embolism of 4 years that I had 4 months ago is coming up again. So that's giving me a lot of worry despite being on the warfarin.
I appreciate your concern, sir. That is a possibility, but I can't say that conclusively until we investigate you further. We may have to carry out some tests to be able to tie it up with whatever we have found clinically. So sorry about that. Okay. I will take care of you in that regard. Do you have anything you are expecting from us that will do for you?
Yes, that my breathing, this difficulty with breathing, pain is sorted out so that I can return back to full activity.
Okay, can you present your case now?
Okay, in summary, I've interacted with a 54-year-old man who complained of difficulty with breathing for 6 weeks, and with retrosternal chest pain that radiates to the left side of the chest. The pain is dull. He is a known patient with COPD and has been treated for pulmonary embolism on a warfarin the past 4 months.
So what are the differential diagnosis that you will consider for this patient?
Differential diagnosis could be a recurrent pulmonary embolism. Yes. It could be a myocardial infarction. It could be angina pectoris. It could be atelectasis. The patient could also have a lobar pneumonia.
How do you plan to manage this patient?
I want to do a detailed physical examination with emphasis on the chest, vis-a-vis the cardiovascular and the examination of the respiratory of the chest and the cardiovascular examination. After doing this, I want to do a chest X-ray, an electrocardiogram, echocardiogram. I want to do arterial blood gases, and also want to do a ventilation perfusion scan, CT pulmonary angiogram.
What are the treatment options that you can offer to this patient?
Okay, treatment option. This patient has been on warfarin. I will also include enoxaparin, which is a low molecular weight heparin. I will give him 40 international units 12 hourly. If this patient is having a recurrent pulmonary embolism, which I suspect, I will do a thrombolysis with alteplase, streptokinase or urokinase. I could also, with a recurrent pulmonary embolism, this patient will also benefit from inferior vena cava filter.
Very good, because of the recurrent attacks. Right. Okay, Dr. Kolade, would you give feedback first? It was good. Yes.
And yes, the history was adequate, as in it covers all. But I think for the infection part, he didn't ask about fever, but I think he asked about all the other part of the history.
Has he missed anything in his history taking?
Yes, that's what I mentioned. The infection. They
Okay.
mentioned he didn't ask for fever, but I think that's the only
But did
only
ask
thing
for
I
weight
know.
loss in unintentional and appetite. The more
Eh,
important was, yes.
Yes, he asked for the appetite. That have I lost appetite and then weight loss? I think he asked weight loss too, but I know he asked appetite. I'm sure of that. I'm not sure that he asked about the weight loss, but I know he mentioned he
did.
tried to rule out malignancy.
Yeah. Right. Thank you so much. So Dr. Tule, you began very well. You introduced yourself. You asked for the patient, but instead of asking age first, name first, you asked for age and name. So maybe ethically it will be good if you can remember to ask name first and then age. Right. And then when you were asking, you have asked very good, very nicely when you were asking about the pain. And when you asked if the pain radiates anywhere, then you can, the patient told you about the severity of the pain. I think you asked between scale of 1 and 10. So patient said 7. I think you did ask, right? Correct me, please.
Yes,
Yes,
ma, I
ma'am.
did, ma.
Yes, he did. Okay, that he asked very well. Okay, so one thing that he could have asked about the musculoskeletal pain, if it is somehow associated, because patient did say pain starts when he's going out for jogging or something. So you can ask, you could have ruled out if it's associated with musculoskeletal. And then you could have asked about orthopnea and paroxysmal nocturnal dyspnea, if patient has ever woken up with shortness of breath in the middle of the night, and if patient sleeps, how many pillows patient normally uses. So these sort of things, character, onset, everything you have asked.
That's noted, ma'am. Thank you, ma'am.
Good. And yes, when you were telling me about the treatment, I would prefer if you can start with that you'll begin the treatment with ABC protocol, as the patient has come to ER and emergency room with dyspnea, and it's increasing, and patient, this is the 4th visit or something for repetitive pulmonary embolism. Patient has intermediate risk as well. So once you're telling me about the management, about the treatment, so begin with ABC protocol. Rest of the thing was absolutely correct. Good.
Noted, ma'am.
Thank you.
Thank you, ma'am.
Timer, and here is your question. Right, so if you have read and understood considering this communication skills station, can we begin?
Yes, ma'am. Good afternoon, sir. My name is Dr. Ajay Abbas. I'm a SHO with Dr. Smith in the Royal Hospital, London. They have been asked to speak to you about a 73-year-old woman who presented with sudden onset abdominal pain, who we're thinking has ruptured viscous and requires urgent laparotomy, and we would like to book a bed for ITU. We've also been asked to request your preoperative advice. May I confirm that I'm speaking with Mr. Mann, please, sir?
Yes, you have.
Okay, sir. The patient is a 73-year-old woman who is a known chronic obstructive pulmonary disease patient, has been on steroids. She presented with sudden onset painful abdominal pain of 1 day duration, and she with progressive abdominal distension. She also has progressive generalized weakness and drowsiness, and subsequently, we had an abdominal pelvic ultrasound scan, which revealed presence of flea fluid and abdomen within her abdomen. We also have done a hemoglobin level, which shows serial hemoglobin levels have shown that the hemoglobin level is dropping. Patient is dehydrated, and serum electrolyte, urea, and creatinine also shows that her creatinine level is elevated and potassium level is low. She also has features of metabolic acidosis with elevated serum lactate, and she's been prepared for urgent laparotomy. I'm requesting. We made a diagnosis of perforated viscous, background chronic obstructive pulmonary disease. I would like to request for preoperative advice, and also post-operatively book the patient for an intensive treatment unit bed. I don't know if this is where I'm calling. Do you have any advice for me, sir?
Yeah, that's noted, but I will ask you a few questions. Why do you think the patient has a perforated viscous?
Yes, sir. Considering the fact that she developed sudden onset abdominal pain, and with associated progressive abdominal distension. Also, the fact that when we did our serum hemoglobin, there was a drop in serial hemoglobin. There was a drop in serum hemoglobin of 2 points, and also the fact that an abdominal pelvic ultrasound scan revealed free-flowing fluid within the abdomen, sir.
Okay, that's noted. Prior transfer to ITU, what would you do?
Yes, sir. I would resuscitate the patient, secure wide bore venous access, and then place on intravenous fluids on 1 liter crystalloids rushed. I would also pass a urethral catheter to monitor urine output. Actually, we'll manage according to the critical care surgical ill patient protocol. Ensure that airway is patent and she's breathing well. I would want to place her on oxygen using the Venturi mask at 24 to 28%, considering the fact that she's a COPD patient, and then also confirm that she's breathing well, and place her on intravenous fluids and pass urethral catheter to monitor urine output and attempt to correct electrolytes, dyselectrolytemia.
Wow, that's noted. Peradventure, you have successfully resuscitated this patient. Are there investigations that you might want to do prior transfer or en route transfer to the ITU?
Yes, sir. I would want to do an abdominal, chest X-ray erect to check for air under the diaphragm. It will also, which will point for diaphragm my diagnosis of a perforated viscous. It will also show if the patient has any underlying chest infection, or to rule out changes within the lungs to rule out chest infection. I also want to do.
That's fine. Why do you think the patient should be transferred to ITU? What are the criteria?
Yes, sir. Considering the fact that she already has COPD, and then she now has perforated viscous, which means she has more than 2 organ systems affected, and also post-operatively, I'm worried that she may require mechanical ventilation, considering she's elderly, and she has underlying lung disease, so she may require, and she has respiratory disease and may require mechanical ventilation. And she already has a chronic, long-standing disease of one system, and I'm worried that one other system is also failing, and then she may require one-on-one nursing. These are the indications why I think this particular patient requires ITU admission.
If you were to be at the ITU, and what can you say about the requirement for this patient in terms of ventilation and oxygen supply?
Yes, sir. I would supply, give her oxygen via a venturi mask.
The comorbidity of this patient.
Yes, she has COPD, so I'll give her oxygen via a venturi mask using an FiO2 of 24 to 28%, in order to not to affect the CO2 drive for oxygen, considering she is a COPD patient.
That's noted. You said this patient also had electrolyte derangements.
Yes, sir.
Which one did you mention specifically?
She has low serum potassium of less than 3.5.
Okay. How would you replace potassium?
Yeah, replacement of potassium, I would calculate deficit, then add the maintenance, and then also give room to add ongoing losses. For the deficits, my aim is to subtract the expected from the observed value, get a value and multiply it by a factor of I expect that the serum potassium of total potassium of 0. For a patient whose deficit is 0.3, total potassium of 100 mils is deficient. So for the guideline in the UK is to use this as a yardstick to calculate. So if for a patient, for example, this patient has a serum potassium of 2.6, she will require 300 millimoles replacement. That I can calculate as a deficit. Then I would add it on ongoing losses.
Peradventure, I only have one bed space left. So, and there's a patient that's booked for that bed space. What are you going to do?
Yes, sir. I would keep her in the and continue her observation in the post-operative PACU, post-op anesthetic care units, until when there's a bed space in the ITU, then we'll transfer. Continue monitoring her.
Yeah, can you summarize this patient once again and paying attention to salient details in the history and your examination finding and your reason for the call?
Thank you very much, sir. She is a 76-year-old woman who is a known chronic obstructive pulmonary disease patient, presented with features of perforated viscous, and she's been worked up for laparotomy, has progressively dropping serum hemoglobin levels with hypokalemia and this electrolyte fluid and electrolyte imbalance, and she's being worked up for surgery and require an ITU intensive treatment unit admission post-operatively.
Good, thank you. So, Dr. Tule, would you give the feedback first?
Well, it was a good response by him.
Yes.
And yes, it was a good response, and he was able to address all the questions asked.
Yes, and
yes.
the issue as well, and he made it a good communication between you two. But about the potassium management, I think he needs to revise more, because I felt he was prolonging more and he wasn't giving a correct or to the point answer.
Yes, ma'am. Actually, well, I guess so. I was supposed to talk about the mode of administration, administering it in not avoiding administering it in bolus, administering it as an infusion, also administering the potassium in Yes, then administering a dose of under ECG monitoring, and then administering at least 40 millimoles in 1 liter or 120 millimoles per day, except one can go above that under ECG monitoring.
Yes.
Yes, ma'am.
And did you discuss about the steroids, because patient was on steroids? So did you confirm if patient was taking steroid took before?
Yes, ma'am. I mentioned it in my initial introduction, but I didn't mention it in the summary.
Yes, there you had to mention, and in this station, especially at the end, you have to summarize and tell the advice that consultant has given you. So remember, in this station, you have to write it down, and at the end, tell the consultant all the advice that consultant has given you.
Yes, ma'am.
Good, thank you. And here is the question. Once you have read this slide, tell me there are 2 slides.
Okay. Okay.
Okay. Yes, please. Were you done reading?
Yes, ma'am.
Okay, so considering it communication skills station, kindly begin.
Hello, I'm Dr. Judge, the ST1, with working with Mr. Smith in the Royal College Hospital. Please, I would request to speak with the cardiothoracic surgeon for a patient which we intend to refer, who has a widened mediastinum on X-ray, which was done with following a road traffic accident. Please, may I confirm if I'm speaking with the cardiothoracic surgeon?
Yes, you're speaking with Mr. Mann.
Okay, Mr. Mann. I would like to discuss with you about the case of a 23-year-old male who came in this afternoon following a road traffic accident with complaints of right chest pain. He's also a non-diabetic. Following presentation and our examination, we noted that his pulse rate was at 120 beats per minute, and the blood pressure was 100/80 millimeter mercury. We also noted or observed that his right thigh was actually increasing in size. Our investigations ordered for the chest X-ray, we noted that he had a widened mediastinum with bilateral pleural effusions, for which a chest tube was inserted into the right side, which yielded about 200 mL of blood. The GCS actually on presentation has been 14. Other investigations done includes an abdominal X-ray, which showed absence swatch shadow. We also did blood investigations, including the HB, the hemoglobin, following the blood investigations was 8 grams per minute. Sorry, 8 grams per DL. So following all this, we think he may be having an injury to one of the great vessels with the amounts of blood in the with the widened mediastinum and also the hemothorax. So we would like to refer him for our experts management on account of this.
Okay, that's good. So what will you do for the cervical spine?
For the cervical spine, we would stabilize the cervical spine with a hard collar. And also during transportation, we would like to put some sandbags beside the head and also tape it to the rigid board to avoid cervical movement.
All right, great. What will you do for the leg?
For the leg, considering the swelling, which I didn't really mention, we had also done a femoral X-ray, which showed a comminuted fracture. We would put we would actually use a splint for that to immobilize the leg.
Okay, so what about the abdomen?
Well, for the abdomen, following the ultrasound scan, abdominal ultrasound scan, which was done, we showed absent swatch shadow and dilated ball loops. It actually means there are collections in the abdominal cavity. Possibly they may have been a ruptured viscous. He will actually need a laparotomy, an exploratory laparotomy. But due to the urgency of the thoracic events, that's why we want to do this transfer first.
Okay. What will you do about the blood pressure?
For the blood pressure, so far we have started intravenous fluids with crystalloids. He has received about 4 liters so far. We've also grouped and cross-matched about 6 liters of blood. However, for this patient, I would like to do a controlled resuscitation, bearing in my permissive hypotension. I wouldn't want him to bleed more, so I would prefer keeping the blood pressure at a low normal level to avoid more bleeding.
Okay. All right. Why do you think the patient has metabolic acidosis?
Well, with the femoral fracture, with a closed femoral fracture, there may be he may have compartment syndrome, which may lead to rhabdomyolysis and the release of myoglobin, which may further affect the kidneys. This could predispose to metabolic acidosis. Also bearing in mind that he could be in hypovolemic shock, which could also predispose to metabolic acidosis. Also, he is a non-diabetic, so we could also bear in mind that he could have diabetic ketoacidosis.
All right, great. So how will you transfer the patient? Who will accompany the patient?
Well, the whole trauma team would come with me. I would be with the patient. I would also have other colleagues from the RTU, the anesthetist, and the emergency nurse would also be with me.
All right, great. Summarize the patient now.
All right, this has been, we've discussed a 23-year-old male who came in this afternoon with complaints of right-sided pain. His vital signs on presentation: the blood pressure was 100/80, the pulse rate was 120 beats per minute. Then the investigations done, the chest X-ray showed a widened mediastinum with some collections of blood bilaterally. Abdominal X-ray also shows absence of the swatch shadow, which possibly there is which possibly means there are collections. He would need to do an exploratory laparotomy, but because of the urgency of the thoracic events, he would need to be transferred. The current hemoglobin is 8. He has received about 4 liters of fluid, and 6 liters of blood has been cross-matched. However, we would like to avoid further bleeding, so we would maintain the blood pressure at a low normal level. That's the lower limit of the normal level, and the cervical spine would be split. Would actually put up a hard collar for him, and tape it adequately to a rigid board, and also splint the fracture, the femoral fracture, before he would be transferred to your facility, sir. I would actually be amongst those transferring him with an anesthetist and a trauma nurse equally.
All right, great. Thank you very much.
Thank you, sir.
You can add 4 liter blood. How much blood? Blood has been cross-matched and arranged.
Mass transfusion.
4 liters of blood and 6 liters cross-match.
4
Yeah,
liters
yeah.
crystalloids.
4 liters of
6
fluid
units of
has of crystalloids
And
has
6
been given.
units of blood.
6 units. Yes, ma'am.
Yes. And what about the CT scan? Have we talked about the CT scan? Why it wasn't available?
Okay, I would like to do a CT scan for these patients, especially for the thorax, which would help us know or identify where the bleeding is coming from. However, our CT scan is under maintenance and will not be available for the next 3 days.
Very good. That
Yes.
was the only point which was left. And drain you have inserted because patient has pleural effusion. Very good. So
Yes,
that's
ma'am.
excellent. Both of you. Yes. Question. Right, so if you have read and understood, considering the clinical examination, kindly begin.
Good evening. Myself, Dr. Kuldeep, one of the surgical candidate. May I know your name and date of birth, please?
Robert Israel, 54 years old.
Robert, today I have asked to examine your breast tissue, which include looking at the breast as well as feeling the breast tissue, and involving the examination of your glands in your arms and in your neck. Is it okay with you?
Yes.
Robert, one of my staff will be acting as a chaperone. Is it okay with you?
Okay.
Just before the examination, I want to ask you, do you have any pain in your
No.
breast? No. Can I proceed?
Yes, please.
Robert, you just sit comfortably on the side of the bed with keeping your arms on bilateral on your thighs. Now I will inspect the front of the chest. I will expose the patient. I will ask the patient to take off his gown and expose the chest as well as the abdomen. And now I will inspect the patient from the front, and I will look. I want the patient to be in the relaxed position by keeping the arms over the thighs. I will check for the asymmetry of the breast. I will check for the skin. I will check for any lump. I will check for the scar. I will check for the nipple. Then I will ask the patient to keep his hand over the hip to strengthen to provide a tension to the pectoralis muscle. It will help to check if there is a mass. It will cause tensioning of the pectoralis muscle and it will become prominent. So we'll check through the whether the overlying skin or there is an infiltration of the underlying muscle or not. Now I ask the patient to keep his hand behind the head and slightly lean forward. If there is any involvement of the suspensory ligament, it will cause dimpling or plucking of the skin. Then I will ask the patient to comfortably lie down, and I will adjust the bed to 45 degree, and I will ask the patient to keep his hand behind his head, and I will ask the patient, now I will feel your breast tissue. Now I will ask the patient again, do you have any pain, Robert?
No.
I will start the inspection. I will do the palpation once on the normal side by rubbing my hands to keep my hands warm, and I will start with the checking of the temperature with the back of my hand bilaterally. Then I will palpate the breast for tenderness. There are 3 methods. I can go with the clockwise method, I can go with the spiral method, and I can go with the quadrant method. I will palpate. I will ask the patient if he has felt any lump then I will start with the from that area. I will check each and every area, and I will palpate with the flat of my hand against the chest wall. I will palpate every tissue. Then I will ask the patient, do you have any history of any? I will check for any lump. If there is a lump, I will examine the lump for size, shape, consistency, fluctuation, overlying skin, mobility in the two planes, or any for the borders. And if and then I will check for the nipple and areola complex. I will ask the patient, do you have any history of any discharge from your nipple area?
No.
And I will squeeze the nipple area with my middle finger as well as the index finger, and I will check for the discharge. If there is a discharge, I will note the volume of the discharge, I will note the color of the discharge, and I will note the consistency of the discharge. And then I will make the patient comfortably sit in. I will ask the patient to sit comfortably, and I will ask the patient to keep his hand. I will hold the hand in. I will hold the patient's ipsilateral hand in my ipsilateral side, and I will palpate the glands in his armpit with my left hand. I will palpate all the group of lymph nodes like anterior, pectoralis, apical lymph node, humeral lymph node, latissimus dorsi or posterior lymph nodes, as well as medial lymph nodes. And I will then I will do the examination the opposite side, and then I will palpate the cervical lymph nodes by doing submandibular lymph node, sternocleidomastoid lymph node, and supraclavicular lymph nodes, and posterior triangle lymph nodes. And if the time permits, I will examine the patient genital areas with the patient's permission. If I will examine the testicular area, I will check for the sign for hypogonadism, secondary sexual characters, as well as I will check for the liver examination.
Yes.
And then I will
yes.
then I will thanks the patient, and I want the patient to dress up, and I will assist the patient in dressing up.
Yes, if needed. Did you ask the patient to push against the wall to check serratus anterior?
Sorry, ma'am, I forgot that.
Yeah,
I will.
It's something you have missed. Yes.
That I forgot, ma'am. Then I will go to the examiner to summarize my history.
Yes.
Yes.
All right, you can begin. You can summarize your case.
Today, I have examined a 54-year-old Robert who presented with the complaints of breast exam. Today I have examined the 54-year-old Robert who presented with the swelling of the bilateral breast tissue for last 6 months, which was on palpation. It was symmetrically enlarged. On inspection, it was symmetrically enlarged. There is no puckering or dimpling of the nipple areola tissue, and it is there is no lump on palpation, and it is tender bilaterally, and there is no mass, as well as there is no lymphadenopathy in cervical as well as axillary lymph node.
So what are your differential diagnosis?
My most probably differential diagnosis will be a bilateral gynecomastia.
Okay, can you please tell me which this bilateral gynecomastia can be due to what causes?
Ma'am, it can be due to liver disorder. It can be due to liver cirrhosis. It can be due to hypogonadism. It can be due to hyperthyroidism. It can be due to bronchial carcinoma. It can be due to testicular tumor. It can be due to drug.
All right. What management or investigation options?
I will investigate the patient with the battery of investigation like liver function test, kidney function test, testicular ultrasound. I will check for hormonal profile. I will check for MRI brain to look for prolactinoma. I will look for look for testosterone level. I look for estrogen level, and I will look for FSH and LH level, ma'am.
Yes.
Luteinizing hormone level.
Along with the routine blood investigation.
Along with routine blood investigation, ma'am.
Okay, and maybe chest X-ray to rule out any chest malignancy. So what treatment options can you offer to this patient?
Ma'am, I will consult the patient regarding the nature of the illness as well after getting the blood investigations. And if it is idiopathic bilateral gynecomastia, I will go for reduction mammoplasty.
Right. Okay, good. Yes, feedback. So what were the things that you have missed? One I've already told you. So
Ma'am, one I missed is the axillary tail, ma'am, actually. I have to examine the axillary tail.
Yes, when you were doing lymph node, then at the same time axillary
Yes,
tail.
ma'am. Yes, ma'am. I
So
forgot that.
visual field, you have to check to rule out hyperprolactinemia, thyroid
Yes, ma'am.
status, and chest examination for bronchial carcinoma. Abdomen, you did tell, but not for the liver enlargement. If time would have allowed you, these are the things you would have done.
Yes, ma'am.
Yes, right. Okay. And when I asked you for the treatment, instead of saying I will do, because in England there is MDT, they discuss the case in a team. So you can say after discussing with the MDT team and after receiving the results of the patient's with tests and investigations, then you will decide accordingly.
Okay.
Yes. So that should be the appropriate way of mentioning. Yes. When you were describing the examination, you said you will start from the right side first. If you consider this case, it is bilateral
Yes, ma'am.
and progressive. So which one is the right side or which one is the normal side? It's bilateral.
Ma'am, actually, sorry, I forgot to ask the which is more affected. I have to ask the patient which is more affected.
Yes.
The part
Which
which is less
giving
affected.
more problem. Yeah.
Yes. I will
Cosmetically
start
or
the
whatever.
yeah. I will start from the opposite side, ma'am. Then I will switch to the more involved side.
Yes. Yes. Yeah. Right, that's it. And in the beginning, I think you forgot to wash your hands as well because it's COVID
Yeah.
era and your examination is going to be hybrid. So to wash hands before and after is very important,
Yes, ma'am.
considering the need of the time, you know.
Actually, ma'am, yesterday also I forgot about washing the hands.
That's why I'm reminding you every day so
Yeah.
that you don't forget on the exam day.
Yes.
Started, and here is your question. Right, so if you read and understood, considering the taking station can be begin.
I will enter the room and I will wash my hand. Good morning, myself, Dr. Kuldeep. I'm one of the surgical candidate. Can I know your name and date of birth, please?
I'm Miss Lily, 54 years old.
Okay.
Yes, go ahead, please.
Today I was asked to ask you few questions regarding that. Is it okay with you?
Yes, please, doctor.
Ma'am, sir, can you tell me how are you and what brings you here?
Doctor, I'm not feeling well. I cannot eat properly and I have difficulty in eating.
Sir, can you tell me, can you describe it in detail? Can you tell me, have it started gradually or it has started suddenly?
In fact, it started gradually. I have difficulty with solid food. Then it gradually start now with the liquid food.
So sorry for that, sir. Sir, can you tell me anything? Is it anything which help you relieving your symptoms and anything which helps you decreasing your symptoms?
Well, I just don't feel after eating. It got stuck and it started vomiting, and I don't feel good.
Sir, when you
And
vomited, is it, sorry to interrupt you, sir, when you have vomited out, is it, it contain blood also?
no, it didn't got that. It contains the food material.
Okay. Sir, can you tell me, when did you notice it for the first time, sir?
It started 10 months ago. I started eating and I feel like I have difficulty in eating
Sir,
meats
have you
and like
noticed,
that.
sir, have you
Yeah.
noticed any change in your appetite recently or any weight loss?
Yes, I noticed that the clothes I'm wearing, it becomes loosens nowadays.
Oh, sorry, sir. Sorry to hear that. Sir, do you feel any lump in your neck?
No, I don't feel such things
Sir,
in my neck.
do you feel any gargling sound while after eating or any swelling in your throat after swallowing?
No, doctor, I don't feel such things in my
Sir,
neck.
do you feel any acid in your mouth, in the back of your mouth, or any heartburn?
No, doctor, I don't feel such things.
Sir, do you have any difficulty in getting up the stairs or any difficulty in opening your mouth or any dryness of your eyes?
No, doctor, I don't feel such things.
Sir, have you visited your general practitioner recently for any medical condition, sir?
No, doctors, I don't have any medical conditions to look up.
Sir, sir, do you have any history of any surgical procedure recently?
No, doctors, I don't have such history.
Sir, do you are you on any on table or prescribed medicine, or do you have any drug allergy, history of any drug allergy?
So far I remember, I don't have any allergy to any drugs or foods.
Sir, can I ask you some personal question, please?
Yes, doctor, please.
Sir, what you do, sir?
I'm a school teacher.
Okay. Sir, with whom you live in the house?
I'm living with my wife at my house.
Sir, do you smoke or do you take alcohol?
Yeah, I'm a chain smoker, but I alcohol occasionally with my
Sir,
friends.
can you tell me how many pack a day? How many pack of cigarette a day?
Um, for the last 5 to 6 years, I took 5 to 6 packets, but now I couldn't be such. I couldn't take such packets now.
Any family member, if you remember, any family member have a similar complaints in the past, sir?
No, doctor. I can't remember.
Sir,
All my family.
Sir, before going ahead, I want to ask you a few things. Sir, what do you think you are suffering from? What will be the cause of this condition?
Doctors, I'm afraid. I couldn't think of any bad of me. I was just thinking that someone said I have cancer, and I'm afraid.
So sorry, sir. Sir, can you tell me what is the most thing which is which you are concerned about?
I couldn't eat. I couldn't drink, and I don't feel any appetite for any food. So that is the most concerned I'm worrying about.
So what are you hoping? What are your hope from us for you?
Please let me back to me and give comfortable situation for me so that I can eat and drink properly. I know what's happening with me.
Yes.
Sir, do you have any
You
chest
can
pain or?
present your history now.
I will thank the patient, and if the time permits, I will include the respiratory, CVS, urinary tract, and rheumatic history also. I have taken the history from 54-year-old gentleman who presented with the progressive difficulty in eating initially to the solid food, then progresses to the liquid food for last 10 months. Patient has the history of weight loss as well as loss of appetite, and he's a chain smoker for last 5 to 6 years.
So what are the provisional or differential diagnosis that you will consider?
My first differential diagnosis will be a carcinoma esophagus. Second will be a gastroesophageal reflux disease, and third will be a ecclesia cardia.
Good. What investigations can you suggest for this patient?
I will thoroughly examine the patient. I will thoroughly examine the patient. I will investigate the patient with the full blood count, LFT, KFT, along with the barium swallow, along with the barium swallow, along with the esophageal endoscopic ultrasound.
Endoscopy, okay, biopsy. All right, okay. What treatment options can you suggest for this patient?
If on the biopsy, after getting CT scan and biopsy results, if it is a operable, after getting the diagnosis, if it is a operable case, then I will go for esophagectomy along with chemoradiotherapy. And if it is a non-operable case, then I will go for a palliation after discussing with multidisciplinary board.
Good. Yes. So what are the, maybe we can just for the fun discuss, if you can tell me, how would you categorize the obstruction or hindrance in the esophageal tract, in the food pipe? How, if you are asked to classify it, how would you do that? Intraluminal, intramural, extrinsic, and then pharynx, body of esophagus, and lower esophagus.
Ma'am, primary constriction of esophagus or the causes of obstruction of esophagus? Dysphagia.
No, not primary constrictions. Causes of obstruction of esophagus.
Ma'am, it can be due to it can be due to the intraluminal obstruction, like for exophytic or fungating carcinoma, or it can be due to intramural pathologies like abnormality of the esophageal constriction or relaxation of the lower esophageal sphincter, like in ecclesia cardia, or it can be due to spasmodic condition, for example, like that. I forgot the name.
The third one is extrinsic, like there is thyroid enlargement if it's upper esophagus, if it's body of the esophagus,
Zinca diverticulum.
Yes.
And thyroid swelling, extrinsic.
And if it's the lower esophagus, then paraesophageal hernia could there be, which can press onto esophagus. These are the extrinsic. Okay, very good. Yes, these you can read and have a look little bit. Otherwise, yes, it's very, very improved. You wash your hands, and then yes, when you were presenting the history, I think you forgot to ask about the stuck and halitosis. If the patient's food stuck to throat or while swallowing, or if there is a bad smelling.
Yes, ma'am.
I think you forgot to even ask if there is any, if patient has noticed any weaknesses anywhere.
No, ma'am,
like
I have asked,
neurological. Did you rule
I have
out
asked, ma'am. Ma'am, I have asked that patient has any difficulty in getting upstairs or downstairs, ma'am.
Yes, that difficulty. Okay, and then I was thinking of the neurological cause or the autoimmune cause. If the patient is suffering,
I try to cover that in one heading only, ma'am, because of the time shortage. That's why, ma'am. Actually, I forgot to ask about the bad breath, because I covered the point of gargling sound.
Gargling,
and but I forgot to ask the bad breath.
Yes, or if it sucks. And then autoimmune, if patient is having or suffering from painfully cold hands.
Yes,
you did ask about the dry eyes and mouth. So there you could have added this as well.
Yes, ma'am.
Good. Rest you covered everything.